Bismillah ar-Rahman ar-Rahim. Let's start our NephroTube teaching case of the month. This month we will talk about an old male with hypernatremia. Before starting, I want to tell you how to reach NephroTube lectures on YouTube. First, write in the search of YouTube, write NephroTube. Then you will find my channel, the first choice. Select the channel, click on the channel. Then once you view the channel, click on playlists. Then you will find different playlists where I am describing different topics of nephrology. This playlist is teaching case of the month. Okay, you'll find all the cases of previous months. Then you will find the hemodialysis playlist in English and the hemodialysis playlist in Arabic, electrolytes and acid base in English, electrolytes and acid base in Arabic. Most of the playlists you will find them in English and Arabic. Little of the playlists you may find them only in English or only in Arabic. Let's start the case, and please respond in the chat box according to my questions. This is a 74-year-old man who is admitted from the nursing home for lethargy, disorientation, and confusion. The nursing record shows that the patient had cerebrovascular accident 5 years ago. Urine output is recorded as 700 ml per day. On admission, the blood pressure is 170, so the patient is hypotensive. The pulse rate is 100, supine, and 80/60 sitting. So we have hypotension in this patient and tachycardia. Okay. Physical examination is normal except for dry mouth membrane. So we have an evidence of dehydration. His weight is 70 kg. Laboratory results of the patient as follows. Sodium shows hypernatremia. Okay. Potassium is normal. Chloride is normal. Bicarbonate is high normal. Creatinine is elevated. Blood urea nitrogen is elevated. And the urine sodium is 12 milliequivalent per liter. And the urine osmolality is 600 milliosmol per kilogram. So this patient is hypernatremic and presented with CNS manifestation, central nervous system manifestation. So it is common for hypernatremia to present with neurological manifestations. What is the pathogenesis of neurological symptoms in case of hypernatremia? Normally, the osmolality of the interstitial fluid of the brain cells is equal or equals the same osmolality of the extracellular fluid. But in cases of hypernatremia, the level of the sodium increases in the plasma, which causes hyperosmolarity in the plasma. This will osmose water from the brain cells to the plasma, which will cause the brain cells to shrink. So in hypernatremia, the brain shrinks, which causes neurological manifestations of hypernatremia. The signs and symptoms of hypernatremia depends on the onset of hypernatremia. Is it acute or chronic? Acute hypernatremia, the patient will present with symptoms, central nervous manifestations, as I mentioned, nausea, vomiting, lethargy, and so on, up to seizures and coma. But in chronic hypernatremia, where hypernatremia develops slowly or gradually over more than 1 to 2 days, the neurological signs are less and the symptoms are less because of brain adaptation. When hypernatremia develops slowly, brain can adapt the loss of water, and by several mechanisms the brain can retake water again which prevents brain cells to shrink. However, some neurological symptoms can be also seen with chronic hypernatremia, but the possibility to have symptoms with chronic hypernatremia is less due to the gradual development of elevated sodium. After we discussed the presentation of hypernatremia, let's start our questions. We have 4 questions for this case. I will ask you, and you have to reply in the chat box. Is the patient's hypernatremia, the patient that I showed to you, is the patient's hypernatremia related to water deficit or gain of sodium? What do you think? I will show again you the case. This is the case. If you want to read it rapidly again. Is this patient hypernatremia is due to sodium gain or water deficit? What do you think? Yes, as most of you said in the chat box, it is due to water deficit. And the evidence of water deficit here appears in the hypotension, tachycardia, low urine output, and low blood pressure, and the dry mucous membrane. So there is a high possibility of dehydration. So to rapidly revise the pathogenesis or the etiology of hypernatremia, the generation of hypernatremia mainly is due to gain of sodium or water loss. So this is the main 2 items or 2 steps for the generation of hypernatremia. But these points are not sufficient alone to develop hypernatremia. There must be other factors that maintain hypernatremia, as failure to sense thirst, as in old age, as the man I showed to you is an old age and he is dehydrated. But as you know that the osmoreceptors are not efficient in old age, so the patient may be dehydrated or with hyperosmolarity, but he cannot sense thirst well, or unable to ingest water due to any reason, due to the inavailability of the water, or the patient has some problem in swallowing or whatever, or the patient is in coma, for example, the patient under sedation, and so on. So we have 2 factors for generation of hypernatremia, and we have 2 factors for the maintenance of hypernatremia. To approach a patient with hypernatremia. How to approach the patient with hypernatremia? They usually classify hypernatremia according to volume status: hypovolemic hypernatremia, hypervolemic hypernatremia, and the avolemic hypernatremia. But we all know that sometimes it is clinically very difficult to assess the volume status of the patient. So actually we cannot depend 100% on this classification to diagnose the cause of hypernatremia in our patients, because sometimes it is not easy to diagnose the volume status of the patient. But let's go through this approach rapidly. In hypovolemic hypernatremia, theoretically, if you measure the urinary sodium and it is more than 20, you will find different causes. And if it is less than 20, you will find other causes. In these causes, if urinary sodium more than 20, all of these causes usually cause more sodium loss, but with more water loss, which is osmotic diuresis, which will cause concentrated blood and hypernatremia. If urinary sodium is less than 20, most of these causes, or all of these causes, will lead to water loss and hypernatremia. In avolemic hypernatremia, usually the urinary sodium is more than 20 because of the polyuria in these cases, as I will show you later. And in hypervolemic hypernatremia, the urinary sodium may be more or less than 20 depending on several factors. But let's talk in more practical way. How to diagnose the cause of hypernatremia. To diagnose that the patient is hypovolemic hypernatremia and there is evidence of hypovolemia, you will find 100%, you will find orthostatic changes, as in our patient. In hypervolemic hypernatremia, 100% you may find edema. Okay, so those are the first two clues in the diagnosis of hypernatremia, to search for orthostatic changes and edema. Second point, you may not be in need for an algorithm for diagnosis of hypernatremia, because in most cases the cause is crystal clear from the history taking and the examination of the patients. If the patient on loop diuretics, you can find this by history. You are not in need to measure urinary sodium or do any investigation to diagnose the cause. Post-obstructive diuresis, this will be very clear in your patient. Vomiting, diarrhea, the possibility of GIT fistula, excessive sweating, burns, saline infusion, intake of sodium bicarbonate or hypertonic dialysis. This is not common, hypertonic dialysis or salt water ingestion. These are not common, but all of these can be excluded just by history. So now we have some causes of hypernatremia that may need to go more deep through investigations to diagnose the cause. For example, osmotic diuresis, primary hyperaldosteronism and Cushing syndrome, and diabetes insipidus, and hypodipsia. Hypodipsia or edipsia is a very rare case. We usually not see it, and it is more common to be present to our colleagues of psychiatry. So how to differentiate between osmotic diuresis, endocrinal disorders, and diabetes insipidus? In case of primary hyperaldosteronism and Cushing syndrome, you may find with hypernatremia, hypokalemia, metabolic alkalosis, and hypertension. It is not uncommon to find all the four criteria, but at least you will find three of them: hypernatremia, hypokalemia, metabolic alkalosis, and hypertension will take you toward the diagnosis of primary hyperaldosteronism or Cushing syndrome. In case of osmotic diuresis, for example, secondary to diabetes mellitus and diabetic ketoacidosis, you will find high blood glucose level, and usually you will find polyuria. In case of diabetes insipidus, you will find also polyuria. So, to exclude the cause of hypernatremia, or to find the cause of hypernatremia, search for orthostatic changes, search for edema, exclude loop diuretics, post-obstructive diuresis, vomiting, diarrhea, GIT fistula, sweating, burns by history and examination, and the intake of these hypertonic solutions. If all of these are negative, check if the patient is polyuric or not, to put the suggestion of osmotic diuresis and diabetes insipidus, and check if the patient has hypernatremia, hypokalemia, metabolic alkalosis, and hypertension, to put primary hyperaldosteronism and Cushing syndrome as a possible diagnosis for the case. Back to our case, we can find here on admission the patient has postural hypotension manifestations. So one of these will be the cause of hypernatremia in this patient. So the patient's, as you said in the chat box, the patient's hypernatremia is due to water deficit rather than sodium gain, as the patient has orthostatic changes. Whatever the etiology, but generally this is due to water loss. In this patient, we have to exclude loop diuretics, post-obstructive diuresis, and these extrarenal causes, and we have to check blood glucose level and the urine output for polyuria. But for sure here, the patient has no polyuria, so we will exclude all these causes. All these causes will present by polyuria, osmotic diuresis, loop diuretics, and post-obstructive diuresis. So the main cause of hypernatremia in this patient will be one of these: vomiting, diarrhea, and so on. Okay, let's go through polyuria. If I have a patient with polyuria, what is the next step? There are different approaches for diagnosis of polyuria. The one I am showing you now is the easiest one and the most rapid one for diagnosis, but its accuracy is not the same as the one I will show you in the next slide, that will use water deprivation test. Rapidly, if you have a patient with polyuria, check urine osmolality. If it is more than 300 milliosmol per kilogram or less than 250 milliosmol per kilogram, it is less than 200 milliosmol per kilogram, check if the patient plasma sodium more than 140 or not. If it is more than 140, so the possibility of diagnosis is diabetes insipidus, and if not, so the possibility of primary polydipsia is high. If the patient urine osmolality is high, here is a diluted urine, polyuria with diluted urine. Okay, this you will find this in diabetes insipidus and the primary polydipsia. But if the urine osmolality is more than 300, you have to check the osmol excretion rate. How to check osmol excretion rate? I will show you this how to calculate this in the coming slides. So if the osmol excretion rate is more than 1000 milliosmol per day, if yes, so this is one of the osmotic diuresis, for example because of diabetes, but for sure you can exclude diabetes just by measuring blood glucose level, or osmotic diuresis due to other causes, and I will show you one of the case reports in the coming slide that causes osmotic diuresis due to intake of high osmoles. But if the urinary osmol excretion is less than 1000, you are facing a case with renal concentrating defect. I mean here there is a tubular defect in the patient which prevents renal concentration. These are for sure rare cases, except for diabetic osmotic diuresis and post-obstructive diuresis. So this is a rapid approach for diagnosis of polyuria. Let's go through the more accurate approach for patients with polyuria. If you have a patient with polyuria more than 3 liters per day, you have to check urine osmolality. According to urine osmolality, you have 3 options. Urine osmolality less than 100 milliosmol per kilogram, that means that there is water diuresis. There is a lot of water which causes a high diluted urine and concentrated plasma causing a hypernatremia. If the urine osmolality is more than 300 milliosmol per kilogram, so you are facing solute diuresis. The patient is losing a solute in the urine, and this solute, but by its osmotic power, causing high urine output and polyuria, which will cause concentrated plasma and hypernatremia. If the patient urine osmolality is between 100 and 300, so it is a mixed polyuria. The polyuria here is due to both water diuresis and solute diuresis. Let's check the causes of each one. In patient with urine osmolality less than 100, so it is water diuresis, so it is a cytogenic polydipsia or diabetes insipidus. Patients with mixed polyuria, this may be due to partial diabetes insipidus, simultaneous water and solute intake, and may be in CKD. If the patient has solute diuresis, for sure this may be due to hyperglycemia or high solute intake or post-obstructive diuresis. In place of azotemia, I will mention post-obstructive diuresis. High solute intake, whatever the route. Okay, intravenous fluids, enteral or parenteral nutrition, exogenous supplements. We have to check the patient infusions if the patient is admitted in the hospital, and check the patient diet if the patient is not admitted in the hospital. So whatever the cause, how I should approach these different osmolality ranges. If the urine osmolality is less than 10 or between 100 and 300, you have to do water deprivation test. If the urine osmolality is between 300 or between 100 and 300, you have to do what is called 24-hour urine collection for estimation of osmosis. Here, this solute diuresis. with high osmolality, which means that there is a possibility of high urine osmoles in the urine. So we have to check urine osmoles. And here this is diluted urine with water diuresis. So we have water deprivation test. And this is mixed between a mix between water diuresis and solid diuresis. So if urine osmolality between 100 and 300, we have to do both water deprivation test and the 24-hour urine collection for estimation of osmoles. You have to measure urine sodium, urine potassium, urine glucose, urine nitrogen, and other osmoles, and I will show you now how to approach this. So water deprivation test is mandatory, but I have to mention rapidly that there is an evidence for now that copeptin can be used in diagnosis of diabetes insipidus. I know that it is not available in many countries, as in Egypt. We don't have options to measure copeptin, but I have just to announce that copeptin, which is a 39 amino acid long peptide derived from the C terminus of free prohormone of arginine vasopress. Its level may reflect the level of ADH and can help in the diagnosis of diabetes insipidus. And there is multiple approaches. This is one of them, according to the copeptin baseline and stimulated copeptin after vasopressin administration. I will not go in depth through this approach and the approach to use copeptin, but you have to read it if you are interested to know more about it. So we have to do water deprivation test, and you now can use the copeptin level regarding 24-hour urine collection. How we do it and how we approach it. For sure, we will do this to diagnose if the patient has solute diuresis or mixed diuresis. We have to do this in solute diuresis and the mixed polyuria too. Okay, how to calculate? How we have to calculate the osmoles secretion. If you remember, in the previous approach, which was blue in color, I told you if the patient has more than 1000 osmoles in the urine, so it is osmotic diuresis, and if it is less, it is a renal tubular concentration defect. So how we calculate the osmoles in urine? To calculate osmoles of urine, you have to multiply urine osmolality by urine volume. Urine osmolality by urine volume. If urine osmolality multiplied by urine volume is more than 900 milliosmol per day, so 100% you have solute diuresis. Let's see this case. This case presented by polyuria, and at last they diagnosed the cause of polyuria was intake of a lot of solutes in the patient diet. Let's check how they calculated the osmoles of urine. First, they calculated the urine osmolality by the traditional equation. We all know it, and you can find different calculators used to calculate urine osmolality. They found the urine osmolality of this patient in this case 209 milliosmol per kilogram. Then daily excretion of urine osmoles, how it should be calculated. I mentioned you have to multiply the urine osmolality by the urine output of the patient. This patient urine output was 7.8 liters. So when they multiplied 209 by 7.8, the osmoles calculation showed 1630 osmoles. So this is more than 900, and in some references more than 1000. So for sure, this patient has solute diuresis. So now we finished first question, which is related to diagnosis of the cause of hypernatremia and whether it is due to water deficit or sodium gain. Let's go for the second question. Now we want to treat the hypernatremia. To treat hypernatremia, we have to treat the cause for sure, and we have to correct the hypernatremia itself. To correct hypernatremia, we have to supply the patient with water. To supply the patient with water, we have to calculate the water deficit of the patient to know how much water the patient needs to supply him or her with. So how to calculate water deficit for serum sodium? The target for serum sodium, or the target that we are using to calculate water deficit for serum sodium, is 140. We know that the normal serum sodium level is between 135 and 145. We will use the average range or the median range, which is 140 milliequivalent per liter, in our equations to calculate the water deficit. Okay, so in our patient, to calculate the water deficit, we have, as I mentioned, to calculate the water deficit. Then, after we calculate the water deficit, the amount, we have to decide the type of water that we will use to replace the patient. And finally, we have to calculate the rate. So we have to know how much water is deficit in this patient. Then what is the type of the fluid that I use to replace this water deficit? Then what is the rate of water infusion that I will do for this patient? Let's start by the water deficit. We calculate the water deficit by this equation, and please take a screenshot of it or write it, because I will show you again our patient in the coming slide or the next slide, and I will ask you to calculate the water deficit for the patient. The water deficit for the patient equal previous total body water multiplied by actual sodium of the patient over desired sodium, and I mentioned that desired sodium will be 140. Actual sodium divided by desired sodium minus 1, and this value will be calculated by previous total body water. This will give you the water deficit. So this is our patient. Please calculate the water deficit for this patient and write it in the chat box. So let's calculate the water deficit of the patient. The previous total body water was 70 kilogram. The actual serum sodium in the patient is 168 milliequivalent per liter, and the desired sodium, as I mentioned, is 140. So 168 over 140 minus 1 multiplied by 42. Here we need the total body water, not the patient weight. Previous total body water. The total body weight water differs from male to female and from old age to young age, but actually it is about 60% of the weight, roughly. So 60% of 70 kilogram is usually 42. Then the final water deficit, as you mentioned in the chat box, is 8.5 liter. Okay, so how, again, calculating the water deficit is not enough to know the volume of water that we need to replace the patient. Why? Because while we are going through treatment, the patient will lose water through sweating, stool, urinary loss, gastrointestinal loss. So we have to add to the water deficit that we calculated, that was 8.4 liter. We have to add about 30 to 40 milli per hour for sweating and stool, and about 50 ml per hour for urinary and gastrointestinal loss. We have to add these to the total point deficit. Okay, I have a question here in the chat box. Total body water, how? 42. Okay, the patient body weight is 72 kilogram. Okay, the total body water is roughly 60 or 65% of the total body in the old age is about 50 or 60% of the total body water, or 55%. Okay, so if you calculated, for example, 0.55 times 72, it will give you about 42 liters, or 0.6 times 72, it will give you about 43 liters. Okay, thank you. So you have to add this deficit also, or loss also, to the water deficit that we had mentioned. You are welcome. Let's go to the next question. Now we calculated the water deficit. Now we have to choose the fluid of administration. This is our patient. We have now to choose the type. We can replace the water deficit by oral tap water. We have multiple infusions, IV fluids. So which type of fluid is suitable for different patients to replace water deficit? If the patient is hypovolemic and there is evidence of hypovolemia, first you have to correct volume deficit by administration of isotonic saline to correct hypovolemia and hypotension, especially in cases of frank circulatory shock. You have to correct this hypovolemia by isotonic saline, because this hypovolemia may precipitate pre-renal kidney injury and acute tubular necrosis. After that, you can correct water deficit according to the volume you calculated. If the patient is eovolemic, you can correct water deficit directly. If the patient is hypervolemic, you have to correct water deficit, but also you have to give diuretics to remove excess sodium and decrease the hypervolemia in this patient. Okay, so here you will calculate water deficit and replace, and at the same time you have to give diuretics. The ideal fluid in the management of hypernatremia, as Dr. Hanan mentioned in the chat box, is the tap water. But sometimes the water deficit volume is too large to be replaced by enteral water. So in this situation, for sure, we will need intravenous fluid. The most suitable intravenous fluid to be used in cases of hypernatremia is dextrose 5%. So for our patient, please answer in the chat box, what is the suitable fluid that must be used in this patient? What do you think? Write in the chat box. As you most of you mentioned in the chat box, yes, this is hypovolemic patient and he has signs and symptoms of postural hypotension. So we have to replace the volume by isotonic fluid. Then we have to correct water deficit mainly by dextrose or oral water. We can use also have normal saline, but in most cases we use 5% dextrose. Okay, let's go to the fourth question and the last one. So in question 1, we diagnosed the cause of hypernatremia, then we calculated the water deficit, then we selected the most suitable fluid for the patient. Now we want to estimate the rate of infusion or the rate of water deficit correction. To decide what is the rate that we have used to correct the water deficit, we have first to estimate the reduction in serum sodium that is suspected if 1 liter of a fluid is infused in 1 hour. Let's take it slightly. We are now targeting to calculate how milli equivalent of sodium will be decreased in this patient per hour. First, for treatment of acute hypernatremia, you have to correct serum sodium with initial rate 2 to 3 milliequivalent per liter of sodium per hour for the first 2 to 3 hours, then and with a maximum total 12 milliequivalent per liter of sodium per day. For treatment of chronic hypernatremia, the treatment of chronic hypernatremia should be more gradual. The correction rate shouldn't exceed 0.5 milliequivalent per liter of sodium per hour for a total of 8 to 10 milliequivalent per day. It is important to measure serum and urine electrolytes every 1 to 2 hours in both acute hypernatremia and chronic hypernatremia, because all what we are using are estimated equations or estimating equations, and there is a possibility, high possibility of inaccuracy on this equation, and there is a possibility of overcorrection or undercorrection even after using these equations. So it is mandatory to measure at least serum sodium for the first day every 1 to 2 hours to be accurate that everything is going as it is calculated. I will pass this. Okay. Now we know the rate of correction of hypernatremia. So we have to estimate the reduction in serum sodium for every 1 liter of a fluid is infused. For example, we will use this equation: change in serum sodium equal infusate minus serum sodium over total body water plus 1. It depends on the fluid that you will use. For example, if we decided to use 5% dextrose for this patient, the infusate sodium, the sodium in the dextrose is 0. If we will use 0.45% sodium chloride, the sodium in this fluid is 77 millimole per liter. If we will use isotonic saline, it has 154 millimole of sodium per liter. So in our case, if we decided to use at first, as we mentioned, isotonic saline. As we mentioned, we will use isotonic saline. So let's check this equation. Infusate sodium in saline is 154. This is 154. Minus serum sodium of the patient is 168. Over total body water plus 1. The end result is minus 0.33. What does this number mean? This number means that for every 1 liter of sodium chloride that I will infuse the patient with, his serum sodium will decrease by 0.33 milliequivalent per liter. So I will ask you now to calculate and write in the chat box what will be the expected decrease in serum sodium if we used 1 liter of 5 dextrose. Please calculate it and answer it in the chat box. Okay, so most of you calculated it between 3.9 and 3. So it is the suspect. So now let's complete the calculation. We know now that 1 liter of dextrose will decrease serum sodium by 3, and we need to decrease the patient sodium because he has acute hypernatremia. We need to calculate to decrease the sodium by 2 to 3 milliequivalent per liter per hour. So we can use 1 liter of dextrose every hour in this patient to decrease the serum sodium by 2 to 3 milliequivalent. I see that you calculated it 3.934. I didn't calculate it, but you got the idea. So now you know 1 liter of dextrose, how much 1 liter of dextrose will decrease serum sodium, and you know the rate of correction, maximum rate of correction per hour and per day. You can do cross equation and you can calculate the volume of fluid, of dextrose, or saline, or whatever that you can infuse the patient per hour to avoid rapid correction of hypernatremia. So finally, my last slide, it must be emphasized that the calculation of fluid deficit is only an estimate based on several assumptions. So it is not accurate. All the equations and calculators we are using in nephrology are not accurate. So although you calculated the patient water deficit and the rate of correction, there may be a possibility of overcorrection or undercorrection. So you have to assess plasma sodium every 2 hours, especially in the first day, to assure that the rate of correction is proceeding as planned. In the chat box you are asking, can we have the lecture please? Yes. All my lectures are uploaded on Mediafire as a PDF and on YouTube as video. I will upload this video today, and you will find under the video in the description a link for Mediafire. When you click the link, you will find a page where my lectures are divided into folders: CKD folder, the teaching cases folder, AKI folder, and so on, and you will find the PDF of all the lectures. To assure an appropriate rate of correction, plasma sodium should be measured frequently. Initially, plasma sodium check should be about every 2 hours. Less frequent checks may occur when the plasma sodium is falling at a predictable rate. And finally, thank you for attending this lecture, and see you next month, inshallah.